Purkinje images are reflections of light, especially infrared light, which can be seen on various ocular anatomical structures. The Purkinje images are named after the Czech anatomist Jan Evangelista Purkinje. A few years later, they were also studied by the French physician Louis-Joseph Sanson. Therefore, they are also called Purkinje-Sanson images. The first Purkinje image is the reflection from the outer surface of the cornea. The second image is the reflection from the inner surface of the cornea. The third image is the reflection from the outer surface of the lens. And the fourth Purkinje image is the reflection from the inner surface of the lens, and is also referred as the lens posterior reflection. Unlike the others, fourth Purkinje image is an inverted image. These images can be used to evaluate the curvatures and separation of the ocular surfaces. Light reflected from the anterior and posterior surfaces of the lens can, in turn, be reflected back into the eye from the posterior surface of the cornea. In this way, the third and fourth Purkinje images can be visible from within the eye itself. The first Purkinje image, the corneal reflection, is generally known as glint, is the brightest of the four. The first and second Purkinje image are almost completely superimposed. Thus only the first Purkinje image is typically used to detect eye fixation since it is brighter. Third Purkinje image is larger than the other images. The differences in size is because the curve of the lens is bigger on the front of the lens versus the back of it. The first and fourth Purkinje images are used by some eye trackers, devices to measure the position of an eye. The first and fourth Purkinje images move together through exactly the same distance. If the eye rotates, however, the two images move through different distance and thus change their separation. The physical separation of these two images, therefore, yields a continuous monitoring of the angular position of the eye, or of the point in space at which the gaze is directed. In strabismus, this test allows us to obtain approximate results of the deviation of the visual axis. Is very useful in children, eccentric fixation patients, where cover test is not applicable, uncooperative patients, patients with neurological problems, and patients with very poor vision such as deep amblyopia. This test also allows us to easily differentiate pseudostrabismus from strabismus. In the photos above, we can see two cases of pseudostrabismus, epicanthus and hypertelorism. The epicanthus can simulate an esotropia and the hypertelorism an exotropia. We see the reflections correctly placed, although it may seem that the visual axis is deviated. In this case, the test is negative and confirms that they are patients with pseudostrabismus. Seeing the photos, we can diagnose a pseudoexotropia in the case of the epicanthus and a pseudoexotropia in the case of hypertelorism. With this test, we can also diagnose strabismus or pseudostrabismus through photos taken with flash. In the case of old photos, it can help us to date the time of evolution of the possible pathology. It can also help us in the cases of patients whose parents report that their children sometimes look away. If their examination is normal, we may request photos in which they have seen a deviation in their gaze. Through these photos, we can help these parents and diagnose if there is a real deviation or it is a case of pseudostrabismus. Julius Hirschberg was a German ophthalmologist. In 1886, he developed the Hirschberg test for measuring strabismus. Hirschberg calculated that each millimeter of deviation corresponds from the center of the cornea towards temporal or nasal at approximately 7 degrees and about double measured in prismatic diopters. A 4 mm pupil is assumed to be normal. Procedure. The patient must not be pharmacologically dilated. Emmetropic patients must be with their adequate optical correction. In emmetropic patients, it will be performed without optical correction. We must use a spotlight bulb. The retinal or a flashlight can be used. We must place the light in front of the patient, focusing on the nasal bridge. The normal scanning distance is between 30 centimeters and 1 meter, and the patient must look at the light source. When the two reflections of light on the cornea are congruent or centered, the patient is in orthotropia, is normal, without strabismus, like in the picture. When this is not the case, one of the reflections must be centered because we are asking the patient to look at the light. Then he will look at the light with the dominant eye, with the fixing eye, and this dominant or fixing eye will be the one with the centered reflection. The deviating eye is the one that will have the reflection at some other point. If the reflex tends to go towards the outside of the eye, it's because the eye is deviating inwards, therefore will have an esotropia. It is important to remember that the positive Hirschberg test, the eye reflex will always deviate in the opposite direction to the axis of strabismus. In the same way, if the reflex deviated towards the nasal side, it is because the ocular axis is deviating laterally. In this case, we must diagnose an exotropia. In the hypertropia, the visual axis of the one eye is higher than the fellow fixating eye. The ocular reflex of the deviated eye moves an inferior direction. Hypertropia is the similar condition, focus being on the eye with the visual axis lower than the fellow fixating eye. The ocular reflex of the deviated eye moves in a superior direction. Well, what are the approximate results of the deviation of the visual axis according to the position of the eye reflex? If the reflex is within the papillary rim, the maximum deviation is 15 degrees, which is when the reflex touches the papillary rim. If the reflex is within the patient's iris and is not dilated, we have not performed a pharmacological mydriasis, the deviation will be around 30 degrees. If the reflection of the deviated eye is on the iridosclerocorneal edge, on the edge of the cornea, the deviation it will be about 45 degrees. In this test, it's important to remember the next. The patient must not be pharmacologically dilated. The eye reflex will always deviate in the opposite direction to the axis strabismus. The eye with the centered eye reflex will normally be the dominant eye. Tests allow us to easily differentiate a pseudostrabismus from a strabismus, and is very useful in uncooperative patients. Thank you very much for your attention. In this video, we will discuss the red-green duochrome test. This test is extremely useful because it will help us to assess the accuracy of the final graduation, and most importantly, avoid overcorrection in myopic person, as this would greatly harm him. The red-green duochrome test is based on the different wavelengths of the red light and green light. Due to ocular refraction, these two wavelengths have different focal points within the eye. The shorter wavelengths, green, are focused in front of the longer red wavelengths. Duochrome test helps you determine position of focal point with respect to the fovea. To do this test, we will assess each eye separately. In distant vision, and at the end of the graduation. When we get both groups of letters to look equally sharp, we will have the correct graduation. An emmetropic person who can see well without the need for glasses or contact lens, or a person who wears the correct optical prescription, will see the letters with a red background and the letters with a green background with equal clarity, as we see here. Seeing the letters with a red background more clearly indicates that there is uncorrected myopia. In this case, we have to increase the myopic graduation until we can see both groups of letters with equal clarity. A nearsighted person should never see a group of letters with a green background better. This would be telling us that he is overcorrected, and that is counterproductive and harms his myopia. In that case, we should lower the number of myopia diopters until achieving equal sharpness. In the case of a patient with hyperopia without adequate optical correction, we will notice that he sees the letters with a green background more clearly. In this case, we will have to increase the hyperopia graduation until the patient sees both groups of letters with equal clarity. Seeing both groups of letters with equal clarity, as in this case, will mark the end of a good correction, both in a hyperopic patient and in myopic one. This test can not only be done with letters, it can also be assessed with circles, with Landau's rings, or with Snellen's S in different positions. In children, it will be very useful to use pictures instead of letters. They will feel more comfortable, collaborate better, and it will be easier to assess their final graduation.
In this video, we're going to review the current and future treatments for age-related macular degeneration, one of the leading causes of blindness. First of all, there are two different types of AMD, exudative or wet and atrophic or dry. Atrophic AMD is much more frequent and it represents up to 85% of the cases of the disease. It is caused by the accumulation of drusen and the inflammation triggered by this. Exudative AMD is less frequent and it is caused by the neovascularization of the macula, which leads to fluid exudation and can cause hemorrhages, which would result in acute blindness. These two types therefore have different etiopathogenesis, meaning that different approaches are needed when it comes to their treatment. For the atrophic variant of AMD, there are no treatments currently approved. The only approach that has gathered sufficient evidence in clinical trials is dietary intake of antioxidants. These include vitamin B and C, beta-carotene, cupric acid, and zinc oxide. This combination of supplements reduces the risk of advanced forms of dry AMD, but more effective treatments are needed to truly change the evolution of this form of AMD. Investigation for new treatments is still an active field of research, which is focusing on targeting various pathways, such as the following. In the visual cycle, vitamin A derivatives may form aggregates leading to lipofuscin. ALK001 is a new drug which inhibits this aggregation. Preventing the accumulation of the protein beta amyloid has been thought to prevent inflammatory induction. However, its efficacy has not been proved. The alteration of the choriocapillaries induces hypoxia and could be potentially responsible for the multiplication of drusen's. Vasodilators such as trimetazidine have been proposed to counteract choriocapillaries atrophy. Oxidative stress plays a key role in this disease. Therefore, to counteract oxidative stress, molecules such as OT551 or bisoticanib have been proposed, as well as molecules such as standospirone which act on neuroprotection. Mitochondrial enhancers such as LMipretide have demonstrated potential efficacy and safety in early phase trials. However, only nutritional supplements have proved to be effective in slowing down progression of the disease. Regarding the inflammatory pathways, complement inhibitors such as sirolimus and the ones presented in the slide are being explored, with variable success rates so far. Gene therapy demonstrated promise in preclinical trials, and phase 1-2 trials are ongoing to evaluate safety and efficacy in humans. Finally, cell-based therapies showed positive effect in terms of improvement of visual acuity, but also raised some concerns about safety in early phase trials. The current standard treatment for exudative AMD is intravitreal injections of anti-VEGF, vascular endothelial growth factor. There are many different monoclonal antibodies approved and used in clinical practice, the most recently approved being faricimab. Faricimab has been approved by the FDA and EMA this last year, and it is a bispecific antibody that targets both VEGF-A and the angiopoietin type pathway. Phase 3 clinical trials have shown its capacity to maintain clinical response with more prolonged treatment regimens compared to aflibercept. Even though current treatments are quite effective, the high frequency of injections, the trauma associated with intraocular injections, the percentage of patients that don't respond, and the long-term adverse effects such as atrophy make this a suboptimal treatment. That is why further investigation is being made in order to find more effective treatments that require less frequency of injections, such as the recently approved faricimab. Therefore, research is focused on finding more durable treatments. Other anti-angiogenic drugs are being investigated, such as abicipar-pegol and conbercept, among others. Other forms of administration are also being studied, such as ranibizumab portal delivery system or PAN 90806, which is administered as a topical drug. Other fields of investigation include the inflammatory and immune components of the disease, as well as the endocrine pathways. Regarding anti-PDGFs, the antiplatelet-derived growth factor upregulates the response of anti-angiogenic therapy, promoting resistance to this therapy. Molecules such as pegleranib are currently in studies for a possible combined therapy to improve the anti-angiogenic effect. On the other hand, angiopoietin 2 is a cytokine that, in association with VEGF, has an effect in neovascularization. Angiopoietin 2 inhibitors, such as faricimab and nesvacumab, are being tested in combination with anti-angiogenic drugs to improve the clinical outcome of the treatment. Besides angiogenesis, several other targets have been explored, including PPAR and integrin receptors, and anti-immune or anti-inflammatory pathways such as mTOR, TNF-alpha, and complement cascade. However, most of these drugs did not go beyond phase 2 of clinical trials because of lack of efficacy or tolerance problems for healthy patients. Other curative strategies, including the use of stem cells, should give a perspective for vision recovery and may be a complete cure if used in combination with other treatments. Studies with human-induced pluripotent stem cells and human embryonic stem cells are currently ongoing. All in all, AMD is a real concern for public health. Its physiopathology is not fully understood yet, and no curative treatments have emerged. Currently, the only treatment for dry AMD is dietary intake of antioxidants. Future trends aim not only to delay disease progression and to prevent its evolution to exudative form of AMD, but also to stop progression and even cure the disease. Regarding exudative AMD, despite the success of anti-angiogenic agents, long-term side effects and the burden of frequent injections and visits impede treatment sustainability and outcomes. Newer agents aim to reduce the treatment frequency while maintaining or improving results. Many of the agents mentioned show promise, but their long-term efficacy and non-inferiority to current treatments need further validation.
In this video, we are going to talk about Sherrington's law. We are going to frame this law within the laws of motor innervation, which are very useful to explain the physiopathology of extrinsic ocular motility. Sherrington's law, or reciprocal innervation law, states that when the acting muscle is stimulated, its antagonist in the same eye relaxes. Whenever the oculomotor center sends an order to increase the tonicity of a muscle, they send another to reduce the tonicity of the antagonist. In other words, when an eye makes a movement in a certain direction, the synergistic muscles contract and the antagonists relax. Let's take an example. If the external rectus muscle of the right eye contracts, its ipsilateral antagonist, the internal rectus muscle of the right eye, will relax. The internal and external rectus of either eye are obviously antagonistic. The superior rectus muscle and the inferior rectus muscle are also considered antagonists since their main actions, in the primary position, oppose each other, although both muscles are also adductors. Similarly, the two oblique muscles of the same eye are antagonists. In this video, we are going to talk about Herring's law. This is the one of the laws of motor innervation, which is framed within the section of extrinsic ocular motility. Herring's law, also known law of equal innervation or law of motor correspondence, is going to refer to the innervation of the muscles of both eyes, of the two eyes. It states that in eye movements, the contralateral synergistic muscles receive equal stimulation. That is to say, the nervous stimuli sent by the oculomotor centers to the ocular muscles for the realization of a movement in a certain direction have the same intensity for both eyes. Thus, in a version gaze movement to the right lateral rectus and the left medial rectus will receive equal innervation since they are contralateral synergists. Its antagonists, the right medial rectus and the left lateral rectus, will consequently relax. If the synergistic muscles are normal, they will respond in the same way and the movements of both eyes will be strictly coordinated. In pathological cases, They will contract unevenly and eye movements will not be coordinated. Here we can see a lattice degeneration. Lattice degeneration is a retinal thinning with loss of neurosensory layer and vitreoretinal adhesion at margin of lesion. Is found in 6 to 8% of patients. Lattice degeneration is a retinal thinning with fibrosis and vitreous liquefaction over the lesion. In the typical form, we find well-delineated thinning with white cross lines. This is the form we present here. The atypical form is found adjacent to vessels, in radial pattern. We can find oval or linear pattern of lesions, maybe one lesion or multiple, may have yellow deposits, pigment, atrophic holes, or retinal tears. There is risk of rhegmatogenous retinal detachment due to vitreous traction or atrophic holes. Retinal detachment is found between 14 to 35% of cases. Prophylactic laser treatment is commonly recommended in patients with vitreous traction and retinal tears associated with flashes and floaters. Here we can see a snail track degeneration. Is defined as groups of glistening white dots, which have been compared to frost granules or salt. Snail track degeneration may be early stage of lattice degeneration. Prevalence found in 10% of general population, more commonly in myopic eyes with 40%. Is a retinal thinning with vitreous liquefaction above the lesion, associated with vitreoretinal traction. More often in superior quadrants, superior temporal and superior nasal quadrants. Histologically, this lesion consists in a degeneration of the neural elements of retina, leading to an atrophy of the tissues with lipid deposits in the internal retinal layers. Complications may lead to retinal tears or retinal holes in up to 54% of patients. OCT findings show irregular retinal surface, vitreous destruction, and vitreoretinal adhesions with traction at the margins. Prophylactic laser treatment should be recommended in patients with vitreous traction or retinal tears associated with flashes and floaters. In this clinical case, the relationship of proximity and continuity of the lesions of lattice degeneration and snail track degeneration reinforces the theory that snail track degeneration would be an early stage of lattice degeneration. Here we can see a white without pressure area. White without pressure is a distinctive white appearance of the peripheral retina without indentation and without mechanical stimulus. Is found in up to 30% of normal eyes, often bilateral, more frequently diagnosed in younger patients, may be associated with longer axial length. Is whiter than the normal retina and the choroidal markings are almost obscured. Found in post-equatorial region at the base of the vitreous and thorax serrata. Whiteness further accentuated with scleral depression, and margins are sharply demarcated from normal retina. Exact cause is unknown. One school of thought states it to be a manifestation of peripheral vitreostructure, while one believes it to be simple and abnormal reflex from a structurally normal vitreous retinal interface. Frequently causes confusion with subclinical retinal detachment and retinoschisis, but indentation clearly reveals that the retina is still opposed to the retinal pigmentary epithelium. No treatment necessary. There is a low risk of association with retinal detachment, so patients are examined every 1 or 2 years.
Here we can see another clinical case of white without pressure. The lesion is clearly defined and the edges are perfectly outlined. Often is bounded posteriorly, as in this case, by a reddish-brown line. Areas of white without pressure frequently are associated with lattice degeneration. 2 zones of lattice degeneration and 1 retinal tear are present in this white without pressure area. And in this another case of white without pressure, we find another frequent association. The snowflake degeneration.
Here we can see a microcystoid degeneration. Peripheral cystoid degeneration is defined as a multiple small intraretinal microcystoid cavities, most frequently seen in temporal peripheral retina. Characteristically, they are yellow tiny vesicles with blurred borders on gray background. Typical form occurs in adults, may be complicated by fusion of cysts, development of cavities in the outer plexiform layer, and flat senile retinoschisis. Reticular form occurs in 18% of adults, may be complicated by bullous retinoschisis with cavities found in the retinal nerve fiber layer. This form is almost always found posterior to typical peripheral cystoid degeneration and tends to follow the retinal vessels. Pointed by the arrow, we can see a peripheral retinal hole. Peripheral retinal tears are defined as isolated tears due to a defect in the sensory retina caused by traction of the vitreous after an acute posterior vitreous detachment. Its prevalence is 9–12% of the general population. Retinal tears or retinal holes are caused by atrophic changes in the neurosensory retina. They have a high risk of complications, such as rhegmatogenous retinal detachment, that occurs in 3–18% of patients. Retinal tears with symptoms on presentation should be treated with prophylactic laser treatment, most commonly transpupillary retinopexy.
Here we see another clinical case of peripheral retinal tear. Look at the retinal hole, a free-floating operculum, and here we can see it immediately after the laser treatment. Initially, a soft retinal whitening is soaked in the laser impact. Finally, this is another clinical case of retinal tear with a free-floating operculum. The laser has been done for a long time ago, and the periphery of the retinal hole shows the typical appearance of a retinal scar. I hope you find this lesson helpful. Thank you so much for your attention. Accommodation is the property of the eye to focus at different distances. In the emmetropic eye, parallel rays from an object at infinity are focused on the retina. If the object is placed closer, at A, the image will be formed at the conjugate focus, A', located behind the retina. And a large circle of diffusion will form on the retina, allowing only a blurred image to be seen. The mechanism by which the converging power of the eye is increased to see clearly A, by moving A' to M', is called accommodation. In the young eye, the refractive power is modified by the change in curvature of the lens. The exact nature of the mechanism of accommodation is still debated, but they do agree on fundamental point, that it is an increase in the curvature of the lens that mainly affects the anterior face. In far vision focusing, the ciliary muscle is relaxed, the fibers of the sonule are tense, and the flattened lens takes on an elliptical shape that decreases its refractive power. In near focusing, the ciliary muscle contracts, the fibers of the sonule relax, and the lens capsule is distended, so that the lens takes on an spherical shape, increasing its refractive power. In the relaxed state, the radius of curvature of the anterior face of the lens is 11 mm. Whereas during accommodation it may decrease to 5 or 6 mm. This variation in shape increases the convergent power of the eye so that the focal point can be shifted as necessary. When accommodating a young eye, there is a shortening of the focal length which corresponds to an increase in eye power from 60 diopters to 70 diopters. How to prevent eye infections due to my contact lenses? Acanthamoeba keratitis, seen here, and other infections can be serious complications that can severely and permanently affect vision in contact lens wearers. What can we do to avoid it? Washing your hands before touching your eyes or handling your contact lenses. Using only disinfecting solution, not saline solution, to rinse and store your contact lens. Never use tap water. Filling your contact lens storage case with fresh solution each time you open it. Not showering, swimming, or using a hot tub while wearing contact lenses. Avoiding contact with contaminated water, which could include freshwater lakes, rivers, and hot springs. Never sleeping in your contact lenses. Not using another person's contact lenses. Replacing contact lens regularly, according to your healthcare provider's recommendations. Prevention is essential. BIP is a mnemonic rule for the treatment of active ocular toxoplasmosis. Not all active ocular toxoplasmosis lesions need treatment. Indications for treatment can be remembered using the BIP mnemonic, which stands for vitritis marked, all lesions threatening a major vessel, immunocompromised or marked visual impairment, pregnant or lesions affecting papillomacular bundle, disc, or macula. Angioid streaks are breaks in the degenerated Bruch's membrane, which typically form around the optic disc and radiate from the optic disc, as we can see in this image. As we can see here, angioid streaks can be idiopathic or can be associated with numerous systemic diseases, the most common being pseudoxanthoma elasticum. A popular mnemonic rule used to remember the most common associations is PEPSI. Pseudoxanthoma elasticum, Ehlers-Danlos syndrome. However, the recent literature has revealed that the association between angioid streaks and Ehlers-Danlos syndrome is weak. Retrospective studies have shown that angioid streaks exist in less than 1% of patients with Ehlers-Danlos syndrome. Paget disease of the bone, sickle cell disease, and idiopathic. Staying long is a mnemonic rule to remember the drugs that are associated with idiopathic intracranial hypertension. The first associated drug is steroid withdrawal. Tetracyclines, vitamin A and retinoids, indomethacin, nitrofurantoin, lithium. Oral contraceptives have been implicated, but linked to idiopathic intracranial hypertension is controversial. Nalidixic acid and growth hormone. And finally, here we can see the entire list of medications associated with idiopathic intracranial hypertension.
I would like to share with you a clinical case. This is a 49-year-old woman from El Salvador who went to dermatology department for a mole on the inside of her right foot. Biopsy revealed a lentiginous melanoma with a depth of invasion of 3 millimeters and a depth of infiltration of level 5. Melanoma was removed, but 4 years later a subcutaneous lesion appeared in the inner region of her right thigh. Additional tests revealed a metastatic melanoma. A molecular determination of mutations was carried out from the tumor biopsy and a BRAF mutation was detected. She was introduced in the sequential combination of immunotherapy and target therapy the second-bit clinical trial for metastatic melanoma BRAF mutated, and was randomized to Arm A, beginning with target therapy with BRAF and MEK inhibitors such as encorafenib and binimetinib until progression of disease, in which case it is transferred to immunotherapy with checkpoint inhibitors, ipilimumab and nivolumab. 2 months later, metastasis improvement was found. The ophthalmic examination before second bit was completely normal. But 6 months later, she had an acute anterior uveitis secondary to BRAF and MEK inhibitors and was treated with topical corticosteroids. According to the second bit protocol, if uveitis is resolved in less than 21 days, medication should be kept. If uveitis is not resolved in 21 days, medication should be reduced or discontinued. 21 days later, our patient didn't improve, and oncology reduced the BRAF inhibitor but maintained the MEK inhibitor. 7 days later, uveitis was inactive, so medication was restarted at regular doses. 6 months later, the patient came to the emergency room with a red and painful right eye with a decrease of vision. Acute anterior uveitis was detected as long as cystoid macular edema in right eye and some cyst in left eye. Again, topical corticosteroids were restarted and oncology decided to discontinue BRAF and MEK inhibitors. In spite of that, the patient not only didn't improve but also worsened, and 3 weeks later, visual acuity was very low. Anterior chamber inflammation was severe with 3+ cells, fibrin clots, and 360 degrees synechiae, and there was vitritis in both eyes, and serous retinal detachment and optic disc edema in both eyes. You can see the macular OCT showing the serous retinal detachment in OD and the serous retinal detachment in left eye, and the optic disc OCT showing the optic disc congestion in both eyes. Treatment with oral prednisone and topical corticosteroids was prescribed. 7 days later, the serous retinal detachment and the optic disc edema had improved in both eyes, and 15 days later was resolved. Oral prednisone and topical corticosteroids were tapered slowly, but when prednisone was at 5 milligrams per day, cystoid macular edema appeared in both eyes, mainly in left eye. At this time, an intravitreal dexamethasone implant was prescribed in left eye. With that treatment, CME disappeared completely in both eyes. A biopsy of a right thigh lesion revealed progression of metastasis, so oncology decided to start with immunotherapy with checkpoint inhibitors, including ipilimumab and nivolumab. But 24 hours later, the patient came to the emergency room for decrease of visual acuity, anterior uveitis, and serous retinal detachment in right eye. An intravitreal dexamethasone implant was prescribed. 7 days later, serous retinal detachment had improved, but there was a new serous retinal detachment in left eye, only 1.5 months after the previous intravitreal dexamethasone implant. Oral prednisone was prescribed, and checkpoint inhibitor therapy was delayed. Serous retinal detachment were resolved in both eyes. At this point, second dose of ipilimumab and nivolumab was decided. But few days later, she went to the general emergency area because of a severe headache, hearing loss, and tinnitus. She was diagnosed with an immunomediated meningoencephalitis and was admitted to the hospital for intravitreal corticosteroids, followed by high doses of oral prednisone. Of course, ipilimumab and nivolumab were stopped. 2 months later, we visit the patient and detected polyosis in eyebrows, eyelashes, and hair. OCT was normal and there was a moderate cataract in both eyes. You can see the difference 1 year later with respect to the polyosis of eyebrows and eyelashes. 4 months later, aside the polyosis, there was vitiligo. Polyosis was more evident, and the patient had diffuse choroidal depigmentation in both eyes. All of these findings were characteristic of Burko-Yanagi-Arada-like syndrome. So the key points of our case are the following. Anterior uveitis, cystoid macular edema, and serous retinal detachment can develop in patients with metastatic melanoma treated with BRAF and MEK or checkpoint inhibitors. Burko-Yanagi-Arada-like syndrome is more common with checkpoint inhibitors. They are usually bilateral and may appear at any moment of the therapy, so regular ophthalmic examinations are recommended. There is no need to discontinue the treatment unless persistent inflammation occurs, and therapy is usually with topical or regional corticosteroids, although oral or even intravitreal corticosteroids are required in the most severe cases. Thank you for your attention.